Good evening, Ankur. How are you?
Good evening, ma'am. All good, ma'am. Should we start? There are no people here.
Good evening, ma'am.
Hi, Srinidhi. We will just wait for 2 more minutes, Ankur, if it's okay. And then we
Yeah,
shall start.
sure, ma'am.
All right, let's start, yeah. Srinidhi. Thanks.
Good evening. Please listen to me. Myself, to me, most uncooked. So, uh, in the axis, it is suggested double blind result was was a answer.
Srinidhi, your voice is echoing.
I'm right.
Better now.
Uh, so it might include and based management. Because of long-term disability mortality, trying to manage the individual candidate is a vital role in identifying post-ischemic injury and improving functional therapy make an important task for prevention. Positively effective drugs to combat improve criminal management. Am I audible now?
No, your voice is completely breaking. I can't understand a single word.
interruption, sir. Sir, am I audible now, sir?
Yeah. Now just speak.
Minocycline.
Yeah. Start.
Minocycline, sorry for the interruption, sir. Minocycline is a broad spectrum, a second generation tetracycline antibiotic primarily used to treat bacterial infection, mostly respiratory, skin, urinary, and STIs, and severe acne. The mechanism is it acts by inhibiting protein synthesis and possesses anti-inflammatory, antioxidant, and neuroprotective properties. The common side effects of this drug are dizziness, headache, fatigue, skin discoloration. Dosing is initial dose is 200 mg followed by 100 mg every 12 hours. As we have already discussed, it inhibits bacterial protein synthesis by binding to the 3S ribosomal subunit. It has the ability to inhibit microbial activation and matrix metalloproteinases. Why specifically minocycline and ischemic stroke? Even with reperfusion, a proportion of patients with acute ischemic stroke remains disabled. Adjunctive strategies targeting secondary injury pathways remains a major unmet need. A post-ischemic evolves over hours to days via neuroimmune activation and matrix metalloproteinase activity, blood-brain barrier dysfunction, edema, and secondary neuronal injury. Minocycline with lipophilic tetracycline with the pleiotropic anti-inflammatory and MMP inhibitory action, early studies and meta-analysis possible functional benefit, but it was limited by small sample sizes and heterogeneous designs. This study, it is a prospective, multi-center, double-blinded, placebo-controlled trial. It was conducted from May 19, 2023 to May 20, 2024. Evaluated efficacy and safety of 4-5-day course of oral minocycline in patients with acute ischemic treated within 72 hours of onset of symptoms. This study was completed. It was conducted across 58 hospitals in China. Committee approval was obtained and trial was listed in clinical trials. Coming to the participants, the included patients from age of 18 to 80 years, ischemic stroke confirmed by CT image or MRI of onset of symptom. The National Institute of Health, that is NIHS score of 4 to 25 was included, and the level of confidence score, that is subscale 1A, was chosen as less than 1. There are first ever stroke or a MRS score 1 or less than 1 was included. The written and informed consent was obtained from all patients or their legal representatives when patient lacks the capacity to give consent. We included two scoring systems, that is modified ranking scale and NIHS score. Regarding modified ranking scale, it is a scale ranging from 0 to 6. 0 being MRS 1 being no significant disability, MRS 2 being slight disability, MRS 3 being moderate disability, and MRS 4 being a moderately severe disability, and MRS 5 is severe disability, MRS 6 is patient scale. This score denotes the functional independence after stroke. To National Institute Health Stroke Scale, this score ranges between 0 to 42. The higher the number, the greater the severity of stroke. The patients which were excluded were who had allergy or resistance to tetracycline antibiotics, severe hepatic or renal insufficiency, pregnancy, or breastfeeding. Coming to randomization and the masking of the patients, the enrolled researchers did not have access to the randomization were masked during the whole process, and the patient was
Srinidhi, you're not heard.
hello.
Yeah, now it's clear. Is there someone else sitting with the system close to you?
No, ma'am. I'm the only person in this
Okay.
room, ma'am.
Because it's echoing repeatedly. Now your voice is clear. Please continue.
The enrolled researchers did not have access to the randomization were masked during the whole process of the study. Patients were randomly assigned in a 1:1 ratio. That is minocycline plus routine stroke protocol. Patients were and the second group received placebo plus routine stroke protocol management. Block randomization with a fixed block size of 4U. The allocation was generated by statistical. The medical and the placebo capsules were identical and packed similarly in a unique labeled number. All patients, treating clinicians and investigators and outcome assessors were fully masked to treat the allocation. Coming to the procedure, the patients in the group of minocycline, the loading dose of 200 mg of minocycline or placebo group received a placebo package and was administered orally within 30 minutes post randomization, followed by a maintenance dose of 100 mg every 12th hourly of minocycline for the next 4 days. All patients were hospitalized. A routine treatment with intravenous thrombolysis and endovascular thrombectomy was given as required. Baseline demographic characteristics, medication use, medication history, physical examination, and details of the presenting stroke and the NHS score was obtained. Blood high sensitivity C-reactive protein was measured in the baseline. Follow-up evaluations were carried out at 24 hours at day 6 and day 90 after randomization by certified investigators. NIHS score were evaluated at 24 hours, 6 days, and high sensitivity CRP concentrations were reassessed at 6 days. The 90-day MRS assessments were recorded by an independent panel of experts who were blinded to group allocation. Regarding the primary outcome, we included excellent functional outcome at 90 days based on the MRS score of 0 to 1. Regarding the secondary outcomes, distribution of 90-day MRS score assessed by ordinal shift analysis and the change in NIHS score at 24 hours and 6 days and change in high sensitivity CRP concentration at 6 days, early neurological deterioration at 24 hours and 6 days, any new stroke at 90 days, any new composite vascular events including stroke, myocardial infarction and vascular death at 90 days, and the quality of life assessed with EQ5D at 90 days, which is not reported in this article. The functional independence based on the MRS score of less than or equal to 2 and independent ambulation with MRS score less than or equal to 3. Coming to the safety outcomes measured in this trial, symptomatic intracranial hemorrhage at 24 hours and 6 days based on the Heidelberg bleeding classification was documented. Antibiotic associated diarrhea, enteritis, and constipation was documented at if any was documented at 6 days. Any bleeding event classified by the global utilization of streptokinase and tissue plasminogen activators or occluded coronary arteries criteria at 90 days. Any vascular death was documented within 90 days and all cause death at 90 days. This safety issues included any investigator reported adverse events or serious adverse events at 90 days. Reports of events were submitted by local trained investigators. Outcome events were reviewed by a clinical event adjunction committee who were blinded to the treatment allocation. Data Safety Monitoring Board, which was blinded, monitored the trial every 6 months to ensure the participant safety and adherence to the ethical standards. Coming to the statistical analysis, the sample size calculation was assumed on absolute increase of 8% of the proportion of patients, participants, achieving an MRS score of 0 to 1 with minocycline group corresponding to a rate of 68%. And 10% dropout rate was documented. A minimum of 1,672 participants, that is 836 patients per group, was estimated to provide 90% power to detect the treatment effect at a two-tailed significance level of 0.05. No interim efficacy analysis was done. A generalized linear model with a log link and a binomial error distribution was used in mixed effect for pooled study center to calculate the risk ratio with 95% of CIs between the two treatment groups. A post hoc analysis without adjustment for study center was also done. The missing data were imputed using per specified multiple imputation and a post hoc worst case imputation scenario, both adjusted for the mixed effect of pooled study to assess their impact and the robustness of the treatment estimate. A shift analysis of the MRS score at 90 days was done to calculate the common odds ratio and 95% confidence interval. A post hoc analysis compared the proportions of patients achieving an MRS score of 0 to 2 and 0 to 3 between the two treatment groups. Any changes in NHS score and high sensitivity CRP concentrations were analyzed with linear mixed model. Early neurological deterioration, symptomatic intracranial hemorrhage, and events associated with antibiotic use were analyzed with a generalized linear model to calculate risk ratio with 95% confidence interval between the two groups. The cumulative risk of new stroke, new ischemic stroke, composite vascular events were estimated with Cox proportional hazard models and hazard ratios, and 95% CAs were reported. When multiple same events were observed, the time to first event was used in the analysis. All safety outcome analysis were conducted based on the safety analysis which was set. A Poisson regression was applied for the analysis of the events. For any bleeding event or vascular death and all-cause mortality within 90 days, the Cox proportional hazard model was used. Adverse events and serious adverse events were analyzed by X-square or Fisher's exact tests. Potential heterogeneity of the effect of minocycline on the primary efficacy outcome was assessed across pre-specified subgroups, including age, sex, previous history of hypertension, diabetes, dyslipidemia, previous ischemic stroke, or smoker or alcoholic usage, baseline high sensitivity CRP concentration, whether the patient received reperfusion therapy, and time to treatment in acute stroke treatment, that is TOAST classification, and based on the baseline NIHS score. All analyses were conducted using two-sided hypothesis testing with a significant threshold of p-value that is significant, that is 0.05. The statistical analysis was performed with SAS, that is version 9.4. No role for the funding source in this study. That is, it is an investigator-initiated trial. Coming to the statistics, total of 1,724 patients were included. Among them, 1,051 patients were male, accounting for about 66.8%, and 573 were female, accounting for about 33.2%. Median age group was 65 years. Median NIHS score at baseline was 5. The 1,724 patients were equally divided into 862 patients in each group. Among these 1,724 patients, 4 withdrew consent. That is in minocycline group and 1 in placebo group. And 19 patients lost to follow-up. That is 9 in minocycline and 10 in placebo group. Interpretation, that is the 90 days MRS score between 0 to 1 was documented in 447 patients, that is 52.6% of minocycline group, and 403, that is 47.4% of the 851 patients in the placebo group. It was clinically significant with a p-value of 0.006. This favor, that is MRS score of 0 to 1 was achieved more in the min group. Coming to the symptomatic cranial hemorrhage, both in minocycline group and placebo group, it was recorded at 24 hours and 6 days. At 24 hours, one patient among 860 patients was had intracranial hemorrhage in minocycline group, whereas none of the patients had intracranial hemorrhage at 24 hours in placebo group. At 6 days, 3 out of 859 patients had intracranial hemorrhage in minocycline, whereas none of the patients had intracranial hemorrhage in placebo group. Other safety outcomes, including the serious adverse events, were compared. There were no significant differences among these two groups. Twenty-three patients did not complete the 90-day follow-up. As previously discussed, 4 patients with the concern, 19 patients were lost to follow-up, and 98 patients were excluded from the per protocol analysis, 48 in minocycline group and 50 in placebo group. The baseline characteristics were well balanced between these groups. The median time from stroke onset to the administration of the first dose of study drug was between 41.3 hours. Coming to the reperfusion therapy or endovascular treatment, among these patients, 244 patients, that is 14.2%, received reperfusion therapy, and 210 patients, that is 12.2%, received thrombolysis, whereas 42 patients, that is 2.4%, underwent endovascular treatment. The concomitant medications administered within 1 month preceding the stroke onset and during the 90-day post-randomization period was similar between both groups. Coming to the result, that is primary outcome, the MRS score at 90 days for 850 patients in the minocycline group was recorded as 98.6%, while in the placebo group it was 98.7%. The MRS score of 0 to 1 at 90 days was significant. It was favored in minocycline group, in which 447 patients had a better MRS score. Coming to the secondary outcomes, the distribution of MRS score at 90 days was significantly favored for minocycline group. This favorable shift was corroborated in the per protocol analysis. The change in the NIHS score from baseline showed minocycline group had reduced NIHS score at 6 days, which was significant, but not at 24 hours after the study drug. A non-significant greater reduction in the high sensitivity CRP concentration was seen in the minocycline group. The difference was statistically significant in the per protocol analysis. There is no significant differences in the early neurological deterioration at 24 hours and 6 days. Coming to the adverse events, any new stroke within 90 days any new stroke within 90 days, 51 patients receiving minocycline had a new stroke, whereas 47 patients had a new stroke within 90 days in placebo group. Coming to death at 90 days, 14 patients in minocycline group were declared, whereas 20 patients were declared in the placebo group. Coming to ischemic stroke recurrence, 4.5 recurrence was observed in the minocycline group, whereas only 5% in the placebo group. Coming to the vascular events, 59 patients of in the minocycline group had vascular events, whereas 52 patients had vascular events in the placebo group. Coming to serious adverse events, among the minocycline group, 40 patients had adverse events, whereas in placebo group, 51 patients had adverse events. The symptomatic intracranial hemorrhage did not significantly differ between both groups either 24 hours or at 6 days. Group analysis suggested the treatment effect modification favoring patient history of alcohol consumption, but the exact mechanism is unknown. Heterogeneity in treatment effect was observed across stroke etiology classified by the course criteria with apparent artery disease and small vessel disease. Post-HOC analysis of secondary outcomes. The MRS score at 0 to 2 of 0 to 2 at 90 days was favored in minocycline group compared to placebo group. But the patients with MRS score of 0 to 3 at 90 days were similar between the two groups. This table shows the interpretation of the results. Shows the distribution of MRS score at 90 days. In the minocycline group, MRS score at 90 days compared to placebo group. The score 0 to 2 was significant, whereas the score of 0 to 3 was not significant. There was no significant difference between the both groups. This shows the efficacy outcomes related to the MRS score and the adverse events associated. Coming to the discussion, a 4.5-day minocycline treatment regimen in combination with the other routine stroke protocol significantly enhanced the 90-day functional outcome based on the MRS score and NAHS score changes, presenting within 72 hours of onset of symptom. An improvement in the NAHS score from baseline to 6 days and a greater reduction in high sensitivity CRP concentrations were observed in the minocycline group at 6 days. The difference in the high sensitivity CRP concentration was not significantly significant between both groups. Minocycline was safe with no significant adverse events and other safety outcomes. Coming to the mechanism discussed regarding minocycline, the biphasic role of microglia, that is the primary immune cell target of minocycline, could initially exacerbate the ischemia-induced injury and later support neural repair. A short course of minocycline during this period was referred to acute phase post-stroke inflammation. Results were consistent with the previous interventional studies. This emphasized studies enroll patients irrespective of the reperfusion therapy to enhance the generalizability of coming to the subgroup analysis. Functional outcomes did not differ significantly between the patients of both groups who received reperfusion therapy and who did not receive reperfusion therapy. Minocycline could extend the therapeutic window for tissue plasminogen activator, and the STAR-X consortium has recommended adjunctive brain cytoprotectants in the context of thrombectomy. This study concludes that combining minocycline with reperfusion therapy could further improve the clinical outcomes after stroke. They extended the enrolling to 72 hours after stroke onset. That is the most substantial deviation from the previous studies. Previous studies will be discussed in the further slides. This modification was guided by minimal microglial activation within the 72 hours, followed by a marked increase thereafter. The pre-specified subgroup analysis did not reveal a significant improvement in primary outcomes in patients with shorter onset to treatment intervals. Administration within 24 hours post-stroke is a promising approach to further clarify the optimal dependent effects of minocycline to ensure when to give minocycline. The short duration of restricted acute pain accounts for the absence of severe vascular benefit over 90 days. Prolongation of minocycline to stop inflammation might confer a greater protection against recurrent vascular event, which is uncertain based on this trial. No clinical benefit in neurodegenerative diseases is Alzheimer's disease based on long-term administration of minocycline. So minocycline effects will differ based on the causative factor in this disease, neurological diseases. There is no specific effects of minocycline. There is no evidence that minocycline reduces the risk of recurrent stroke or ischemic stroke or complex vascular events, which aligns with its proposed mechanism of targeting the neuroinflammation rather than the atherothrombosis process. Patients with tropic lateral sclerosis, minocycline accelerated the disease progression. Hence, based on disease, minocycline should be decided whether it's beneficial or not. Timing, dosage, and timing and duration of minocycline treatment can differ across diseases. Other preclinical stroke models indicated that minocycline did not interfere with fibrolysis and could reduce hemorrhage, improve neurological outcomes, and reduce mortality. This trial showed bleeding did not differ between placebo group and the minocycline group. Other adverse reactions were similar in groups. Short-term use of minocycline during the acute phase of ischemic stroke appears to be safe and it is well tolerated based on this trial. Coming to the limitation of this trial, study and regional differences. As in trial, only patients of Chinese origin were included. This study set an upper age limit of 80 years for enrollment owing to concerns that older patients are at higher risk of complications and disability. This result might not be applicable to non-Asian populations or to individuals older than 80 years. This finding primarily
Srinidhi, we've lost you.
Ma'am, am I audible now, ma'am?
You're audible, but your screen is not seen.
Right now, ma'am?
Yeah, now it's seen.
The proportion of patients with excellent functional outcome and the were lower than expected, actually reducing the statistical power of results. The borderline statistical significance of the findings represent important limitation during the study. Regarding high sensitive ERP concentrations, trial were between two groups. Under stratified classification design, these
Your
specific
voice is
differences.
breaking, Srinidhi. Are you on a Wi-Fi? Then go on to your network, mobile network.
I'll change it now.
Speak up now.
Are the slides visible now, ma'am?
Yeah, visible.
Regarding high sensitivity CRP concentrations, this trial it was not centrally analyzed. The central stratified block randomization design mitigated these site-specific differences between these groups. A block randomization with a fixed block size of 4 posed a minimal risk of allocation predictability, but blinding and identical study drugs mitigated this. Potential discrepancies between the preclinical models and the clinical patients highlights the need for further investigation into the mechanism of minocycline in acute stroke. Discuss about other articles on minocycline in acute stroke. This article showed the mechanism of damage and cerebral ischemia reperfusion injury, which was published in a European Journal of Pharmacology. This article summarized the mechanism underlying the protective effects of minocycline against cerebral ischemia reperfusion injury and in alleviating complication, suggesting that minocycline in cerebral ischemic reperfusion injury was beneficial. Coming to acute ischemic stroke, which this study was conducted in 2012, placebo-controlled trial, but the sample size was only 50. This showed promising safety and efficacy with the minocycline group. Minocycline initial dose was 200 mg, followed by 200 mg twice daily was given for 5 days in this study, which significantly improved NIHS score, MRS score, and bar score at 90 days to placebo, and there were no reported serious adverse events. This is an ongoing trial that is effect of oral minocycline on acute stroke. It is a randomized open-label prospective study. This study included 1,164 patients, that is adults with moderate stroke, that is ages of 5 to 20, within 24 hours of symptoms, whereas the emphasis study patients within 72 hours of symptoms. These patients received 200 mg of minocycline once daily for 5 days, along with the standard stroke care and the standard stroke or placebo, that is standard stroke care alone. The study measures the NHS score and the MRS score at hospital discharge 30 days and 90 days after this stroke. It also monitored for death and bleeding complications. The goal was to see whether minocycline, in addition to usual, improve recovery and survival in patients with acute stroke.
Thank you.
The study was conducted in 2007, that is minimum treatment in acute stroke. It is also an open label study, evaluated blindly. It was conducted in 152 patients, where 72 received minocycline and 77 received the placebo. The NHS score and MR score was significantly lower, and these scores were significantly higher in minocycline treatment on day 7 and day 30 of follow-up. Deaths, myocardial infarction, recurrent strokes, and hemorrhagic transformation during the follow-up between both placebo and minocycline group. There is a phase 2 trial in 2011 which confirmed IV minocycline safety even with thrombolysis and study, which was conducted in 2019, showed the effect of oral minocycline on acute outcome. It was a randomized open-label process study. The patients received oral minocycline 200 mg daily for 5 days for patients with acute ischemic stroke within 24 hours of onset of symptom. And they assessed the NIHS score and MRS score at 90 days. The study was limited due to lack of sufficient evidence. There was limited clinical evidence from large-scale randomized placebo-controlled trials to support its continued routine application. The decision followed a consensus decision among the stroke clinicians at that institution. Coming to effect of oral minocycline on clinical recovery process in patients with acute ischemic stroke, a randomized trial which was conducted in 2017. This study aimed at evaluating the effect of minocycline in the recovery of patients with a history of stroke. 42 patients with ischemic stroke were divided into two. One group received minocycline 200 mg for 5 days, whereas the other received placebo. Aspirin was prescribed to all patients. 36 patients among 42 completed the study. In minocycline group, NIHS score decreased from 9.5 to 6, and in the placebo group, it decreased 10.2 to 7. This difference was not statistically significant. This study suggested that minocycline could be used as a complementary therapy in patients with ischemic stroke without any adverse events. The MINO study, that is MATRIX metoproteinase 9, included trial of intravenous minocycline for acute ischemic stroke. Combining minocycline with TDA may prevent adverse consequences of thrombolytic therapy through suppression of matrix metalloproteinase 9 activity. The matrix metalloproteinase 9 level decreased at 72 hours in patients who had minocycline compared to the baseline. Slow than the non-immunosuppressive group at 20 hours. Both in 72 hours, 24 hours, MMN9 still minocycline group. Thus, improved very after ischemic stroke. This study was a multi-center randomized double-blind placebo-controlled. At two groups or placebo was administered within 3 to 48 hours in advance. The 13 subjects were included in this study. Again, no significant difference was noted in the MRI score, less than or equal to 1. 56% in minocycline group compared to placebo, with 51%. Odds ratio of favorable outcome in the minocycline group compared to placebo was 1.2. There is no difference recorded in NIHS score, limits or vascular events. No safety concerns were identified between both groups. Oral minocycline administered for acute ischemic stroke was ineffective in improving a functional outcome. It was a negative study.
Srinidhi, let's stop
Yes, ma'am.
comparing the previous studies. Let's discuss this study.
Okay.
Okay. Can you
Okay.
go back to the methodology? Why did we have per protocol analysis? Why didn't we have intention to treat? Would that have made a difference to the result? What were the patients excluded? There were 3 major categories of patients excluded, no? Go to that table.
This hepatorenal insufficiency and pregnancy of breastfeeding patients.
There is a group with 94 patients excluded, no? Why were they excluded? There is one figure you have put, no, which gives the arms. Yeah. The previous one.
This one.
No, this is the result one. Before this, you should, yeah, here. There is a group in, I think, one before this also. One in which you have 94 patients taken off. The exclusion criteria you show.
Patients are excluded from the per protocol analysis. 48 in minocycline group and 15 group.
Okay, the total is 94. So which is better? Intention to treat is better or per protocol is better?
I'm not sure.
Hey, the journal club is for you to understand the article, man. Okay, a more generalized, if you were to be given minocycline, or if one of your relatives is having an ischemic stroke and you were to be given minocycline, would you consent or will you not? Based on this trial. From all that you spoke, what is the takeaway message? How many percentage of those treated with minocycline are actually showing a functional outcome improvement, based on which you'll make this decision? Where is your results figure? There's another slide with the results figure, no? Show that. If I'm not mistaken, it's only 48% of patients receiving minocycline improve. The chances are even
Yes,
less than
ma'am.
50-50.
Yes, ma'am.
So would you consent? Would you not consent?
Not ma'am.
But without it, any additional benefit from interventional therapy is also not possible. At the same time, you're not having many side effects. So then where does that leave you?
No, there are no gives
I can't hear you, Srinidhi. Your connection is really poor. We can't hear you. Say again. Ankur, you want to chip in?
Yes, ma'am. Like what you were asking that we should be giving minocycline or not based on the study?
Yeah.
Yeah, so I think it is safe, low-cost adjunct that modestly improved functional outcomes. Though there were slight limitations to this, that there was population was only Chinese, and they took only minor and mild strokes. Not it cannot be generalized to a more diverse population in the world and more severe strokes, where probably minocycline might not show that much benefit that it showed. Though the benefit was modest, but because it's a safe, low cost, and did not have much side effects, the trial can be started. More studies can be tried in a population who are having severe strokes, whether functional outcome actually improves or not. So further studies can be, warranted with that.
Correct. So it is not something showing a out of the way
Very, yeah,
benefit
yeah,
to guideline, but at the same time, there is not many side effects.
yeah,
So why not use? We
yeah,
are at the equipoise kind of a thing. Like you said, there will be more robust studies that will need to be done,
yeah.
probably more statistically powered. And at the moment, even the latest AHA guidelines doesn't say anything about neuroinflammation or
And
any
neuroprotection, yeah,
other.
starting protecting
Correct.
agent at the very early stage.
Protecting agents are nowhere in the guidelines. So this is the beginning. So many more trials are to come on these lines before something can be made of it.
Yeah,
But yeah, taking consent would have been really tough in this. On what basis would you consent? What did they say? It will be very interesting to see that.
right. Srini, you didn't understand the concept of intention to treat and per protocol, or did you understand? Hello, is she there?
Srinidhi, question is to you.
Or any other fellow who wants to chip in and talk about what is intention to treat and what is this. This has been discussed so many times in during general clubs, and many articles have the same thing. Yeah, anybody? Is anybody listening, or is everybody's off?
I think there are more consultants than fellows.
That's the problem. Not many people joined today. I don't know what happened.
I think we'll leave that as a homework for the rare fellows who did join in.
Yeah,
But that is a basic, at least we should know before we do a journal club. But
right.
thank you for your efforts, Ankur. It was a very interesting article. And
Yeah.
Sri, if you're here, thank you very
Yes,
much.
ma'am.
You were asked a question. Do you want to answer it? What
Ma'am,
is the
regarding
difference
per
between...
protocol,
Correct. Go ahead.
What is the difference between intention to treat and per protocol?
mm,
You understand the basic concept behind it?
Per protocol demonstrate the efficacy of an intervention, sir.
So what is per protocol? What is intention to treat?
Um, per protocol focuses on um, evaluating the efficacy of treatment in, sir, what we give, sir.
Those who adhere to the assigned treatment without major deviations are included in per protocol. You understand? Whereas intention to treat includes everything which after randomization which was started. Do you
Okay,
understand?
sir.
If there is a
Yes, sir.
deviation, major deviation in the protocol, then there are patients who are excluded out of the per protocol but are included in intention to treat. So which is more robust? Which is more beneficial? That's what ma'am asked.
Per protocol will be beneficial, sir.
This is homework for you. Try to understand the concept
Okay, sir. Okay, sir.
and then tell. Here, what did they use?
Per protocol, sir.
But what happened in the primary analysis, which was a modified kind of ITT? For a secondary sensitivity, they use per protocol, yes. But both were actually very similar in this study.
Yes, sir.
So you read about
They
it
use
carefully.
per protocol in secondary, sir. I'll read it in, sir.
Yeah. So test efficacy was there in adherent, but it was actually what was the bias and what are the problems shared with those two protocols. You should be able to answer. You should understand what the article wants to say.
Okay, sir.
Yeah.
Okay, then. Thank you for all your efforts, Srinidhi. We'll wind up for
Thank
the
you, ma'am.
night.
Thank you.
Thank you, all the listeners. There was one answer, Ankur, on the chat, and he was great. Hit the nail. Thank you all.